Hi, my name's Corinne Young. I'm a nurse practitioner. I've been in pulmonary medicine for about 20 years. I'm also the president and founder of the Association of Pulmonary Advanced Practice Providers. And I have been taking care of Alpha 1 patients. Not only the 20 years I've been in pulmonary medicine, but even prior to that, I worked in infusion centers where we also used to infuse Alpha 1 patients. So the topic of Alpha 1 is near and dear to my heart. And today we're going to explore why focusing solely on FEV1 misses the bigger picture of Alpha 1 and COPD and how we can better assess and care for these patients. All right, so why would we look beyond FEV1 when the cornerstone of treating COPD patients is looking at the FEV1? Well, the reason why is that it doesn't fully capture the symptom burden of these patients, their complete exacerbation risk, because we do know the lower their FEV1 is, the more likely they are to exacerbate, but it doesn't capture all of the risk factors for their exacerbation risk. Quality of life in these patients is not directly captured in FEV1, and of course, the systemic effects of alpha-1 antitrypsin deficiency and COPD itself is not captured by that measurement. We've all had patients who tell us, why do I feel worse when my FEV1 hasn't changed or maybe even got a little bit better? And that's because lung function decline is just one part of the story. The forced expiratory volume in the first 1 second, that's what the FEV1 is not a reliable standalone predictor of a patient's symptoms or their quality of life. The correlation between FEV1 and the patient-reported outcomes is very weak, and patients with the same FEV1 can have vastly different symptoms and burdens of their symptoms and quality of life. And as an example of that, I've given us a case study here looking at 2 different patients with the same FEV1. So our first patient, patient A, has an FEV1 of 45%. They're severely fatigued. They're still smoking. They have osteoporosis with fracture. They're very inactive and they're depressed. Okay. Our second patient has the same FEV1 of 45%. They're living an active lifestyle, actively engaged in pulmonary rehab. They have a strong support system, and they quit smoking about 5 years ago. So although their FEV1 is exactly the same, these are vastly 2 different patients. They're going to have very different experiences with this disease. With our patient A likely having more symptoms, utilizing more healthcare resources, having more exacerbations, and poorer mortality rates as well, the less active they are, and of course, having other comorbid conditions. So just to keep in mind the numbers, not everything in these patients. Now, some strengths of FEV1 that we all know is that it does help us understand disease progression as we do trend their lung function over time. It does help us predict exacerbations and hospitalizations related to those exacerbations, and they all start to feed each other. So the lower the FEV1 is, we know the more progressed the disease is, which increases their exacerbation risk, which leads to oftentimes hospitalizations. And the very unfortunate thing about patients who get hospitalized for exacerbations is how high their mortality is in the first 1 to 5 years of having a hospitalized exacerbation. Just one of those hospitalized exacerbations increases mortality dramatically in our COPD patients, and our Alpha 1 patients with COPD are no exception. Now, some areas of limitation when it comes to FEV1 would be the weak correlation between FEV1 and quality of life, QOL. That's our quality of life scores. So studies have shown weak negative correlations between FEV1 and disease-specific quality of life questions like the St. George Respiratory Questionnaire or the Modified Medical Research Council, the MMRC dyspnea scale. And so we know these are not directly correlated. So although their number may be 1, level on their FEV1, and it could be a very high FEV1, that does not tell us about the patient's quality of life. We also have been able to study why is there such a difference between FEV1 and quality of life scores, and depression is often the reason. So when there is that disconnect, oftentimes that reduction in FEV1 can be explained up to 30 to 67% of the time by depressed patients, Whereas if we look at the impact of FEV1 on quality of life, it was only 1 to 4% impact. So alpha-1 is more than just a lung disease. Specifically, it's more than just emphysema. It's a deficiency that drives inflammation and tissue damage in multiple systems. We know it can affect the lungs, it can affect the liver, and it can affect the skin in patients. In regards to liver disease, these patients are at higher risk of developing cirrhosis and hepatocellular carcinoma. Patients can just have liver disease alone. They can just have lung disease alone. They can have a combination of both. And so something we want to be screening for and talking to patients about. And sometimes in pulmonary medicine, we're not always thinking about other organs all the time, but definitely we want to make sure we're making time to counsel these patients on risk factors related to liver health, avoiding alcohol, acetaminophen use, limiting that, talking to them about vaccinations related to liver disease, like hepatitis vaccines and hepatitis precautions in general. These patients also are at a little increased risk of cardiovascular disease. We know COPD and cardiovascular disease do go together and share increased risks. These patients also are at a higher risk of pulmonary hypertension, specifically group 3 pulmonary hypertension related to underlying hypoxia from their emphysema disease, and some COPD sleep apnea overlap can also happen in those patients. When we look at metabolic and bone health, these patients are at a higher risk of developing bone mineral density issues, especially the ZZ phenotype patients. And they have a higher risk of osteoporosis compared to the general population. A lot of that, again, is smoking history that increases their risk, exacerbation history, where we're giving them oral corticosteroids, maintenance therapy that we're giving them inhaled corticosteroids on a daily basis. All of those things do impact their bone density. Diabetes also, and frailty that comes with that, which of course in our female patients, that's a big mortality risk for them if they are starting to fall and have fractures, a big concern for those patients. As far as mental health, these patients do suffer a higher risk of depression related to chronic disease state, anxiety over their symptoms, their progression disease, loss of independence, and isolation, especially patients who have alpha-1. Our COPD patients already feel pretty isolated, but add alpha-1 on top of that, which is a rare genetic lung disease. Oftentimes they're not exposed to others in their community that may also have this condition. And so there is that sense of isolation. So when thinking beyond spirometry tools for these patients, what else could we do outside of FEV1 to be monitoring and treating and helping these patients? CT densitometry for looking at emphysema progression. This is usually utilized in research trials, but it does help us identify emphysema earlier than we could with the naked eye looking at a CAT scan. In very, very early emphysema, diagnosing that can be very subjective to who's looking at that scan. But the densitometry is literally looking at density of the lung tissue, and it becomes less dense when emphysema is present. This does allow for early and precise diagnosis of emphysema. We measure by Hounsfield's units, which we're using in other areas of measuring density in and outside of the lung on CT scans. However, the limitations of this is cost. CT scans are expensive. There's a lack of standardization of what really normal should be, where's our cutoff for ranges of severity, maybe even of how dense or less dense a lung tissue is. You do need to have some specific software to measure it. And then, of course, radiation exposure to patients. Now, over time, AI may actually help us with this, with helping even review older scans, lung cancer screening, or whatever other scans that patients are having, and maybe be able to run it through AI and give us a densitometry number for us in the future, possibly. A lot of radiology AI innovations are coming, and so it'll be very interesting to see if this is something that may smooth out, become more of an option for us in the future. 6-minute walk test assesses functional capacity. It provides prognostic information. It identifies exertional oxygen desaturations earlier than we would see just at rest with our patients. It's practical and easy to perform. Most offices can do this. Helps patients with another objective measurement of their functional capacity. Some limitations to 6-minute walk, though, are if the patient has musculoskeletal or joint dysfunction, oftentimes their body is limiting their 6-minute walk distance versus their breathing. And so that can skew the results there. Now, as far as biomarkers go, these biomarkers hopefully will help us understand the phenotypes within the genotypes. So we could have two different ZZ patients, and ones that develop horrible disease and ones that don't. And that is very difficult for us all to understand why one patient with the ZZ genotype may develop very severe emphysemic disease or liver disease, and where another patient may not develop any lung disease at all. So biomarkers may help us understand that a little bit better. And there are many that are being studied right now, looking at elastin degradation, fibrogen degradation, looking at things like circulating polymers and some other plasma proteins that might be markers of inflammation for us to understand this a little bit better. So more to come on that. These are kind of under development. PROs are patient-reported outcomes. So that St. George Respiratory Questionnaire, we talked about the NMRC, we talked about. So these are helping us understand the patient's lived experience with the disease, what their active in real-time impact of their quality of life, activities of daily living, and symptomatology are utilizing these tests. And there's many of them. Some of them are very short, like the CAP, the COPD assessment test, and the MRC is only 4 questions, I believe, 4 or 5. And the GRQ, the St. George Respiratory Questionnaire, is a much longer exam, usually used in research as well. There is also some routine comorbidity screening that we should be doing for our patients. So again, liver disease we touched on a little bit. We should be looking at impacts on their liver function. DEXA scanning for that bone density. These patients, again, are higher risk of developing bone density issues. Mood scales, which I don't think we're often doing in pulmonary medicine, but again, looking for those depressed patients because that does impact their outcomes. These patients are, if they do have high depression scores, they're less likely to be compliant with therapy, less likely to show up for follow-up visits, less likely to be engaged in their care, which is so important for these patients. Echo evaluations, echocardiograms, looking for, again, pulmonary hypertension or even overlapping left heart disease or valvular disease that might be being masked as respiratory dysfunction as they're becoming more breathless. And then, of course, vaccine screening in these patients, which is a very hot topic for a lot of patients, but just at least letting them know what their risks are with and without vaccination to protect them from not only the respiratory vaccines that they should be getting, but also the liver hepatitis vaccines that they should be up to date or getting as well. And the last thing is looking at early referrals in these patients. Pulmonary rehab, as soon as you have a pulmonary function test showing that they have obstructive lung disease of any kind, they would be a candidate for pulmonary rehab. Smoking cessation, if they're still actively smoking, there's fewer and fewer smoking cessation programs around to refer patients to. There's still the 800 numbers that we can refer them to. If you're lucky enough in your center to have a smoking cessation program, it's great to get these patients involved if they still are actively smoking. And then palliative care. Most all of them qualify for palliative care right out of the bat. And again, the goals of palliative care is focusing on quality of life in these patients. Transplant, discussing transplant early with these patients. Oftentimes, the transplant cutoff for COPD is higher in the patients who have alpha-1 with COPD versus patients who have alpha-1 without have COPD without alpha-1 deficiency. So you want to make sure that these patients are screened a little earlier than your patients who do not have alpha-1 deficiency and talk to transplant centers earlier. And then lastly, hospice. And that shouldn't be the last thing that we discuss with our patients. That should be something we talk about very early on. Although patients may not be ready for hospice or be necessarily actively dying, we want to engage them and talk to them about hospice before they're actively dying. There's so many resources that hospice can provide for the patient and the family, regardless of their how severe their disease state is. And unfortunately, if we wait until the patient is actively dying, there's very little resources that hospice can actually provide them. So having that conversation early before you have to have the conversation with them is what we definitely would recommend. Now, as far as treatment implications, a lot of these patients with COPD with alpha-1 antitrypsin deficiencies with lung disease is where we have augmentation therapy options for these patients. When we start these therapies for patients, there are some things that may impact their quality of life and outcomes in these patients as well. We know augmentation therapy slows the emphysemic process for them, but it doesn't stop the disease. It doesn't reverse the disease. And there can be some systemic impacts of therapy. And so a lot of patients, sometimes that's a hard buy-in for them if they know they're going to be on a therapy that's every single week for the rest of their life. That is not going to necessarily make them feel any better, improve, outcomes or as far as like their quality of life or symptomatology. There's been some very small studies showing some improvements in reducing their exacerbations and some quality of life scores, but they're pretty small studies and pretty low outcomes. And so oftentimes patients are discouraged by that fact when it comes to their augmentation therapy. There's also side effect potential. Anytime we give patients therapies, there can be side effects. And the most common are kind of flu-like body aches, headaches that can happen with therapy. Much more rarely, we can have rash, hives, itching, difficulty breathing with the therapies, especially with our patients who may have IgA deficiency. They may be more likely to have the rash, issue there. And then the whole logistics around getting the infusion. Most infusion can be done in the home. I've had infusion nurses that meet patients at their workplace and help, infuse them there. The infusions luckily are not very long. They can just be between, 20, 30 minutes for a lot of patients from start to finish. However, it is time out of their day. They have to do every week. If they're still working full time, this can be very impactful. Them to take time off work to get infused. If their work won't allow them to do infusion while they're there. Transportation is also a big issue. Some of our Medicare patients have to go to infusion centers for a cost benefit. And getting to the infusion center can be very difficult, especially if they're not driving themselves or don't have transportation. Cost is always a concern. This is an expensive therapy for patients. And again, it's weekly for the rest of their life. And there's also concern about supply chain issues. So this therapy comes at the cost of coming from the generosity of plasma donors. It takes approximately 900 plasma donations to treat one patient for 1 year. And so if there's a reduction in plasma donations, if there's a bad supply, if supplies are ruined in transport, manufacturing issues, that can impact patients receiving their infusion therapy down the line. All of this can cause anxiety in the patients, thinking like, what if? What if there's a government shutdown? What if there is a grid shutdown? What if something happens? I'm not going to be able to receive my therapy. And so it does weigh on your patients, and something just to kind of talk to them about planning those types of things. All right, so future directions of thinking about treating these patients outside of looking at their FEV1, their lung function over time. The first one is the integrated multidisciplinary care. There are patients who are lucky enough to get to large centers where GI and cardiology and pulmonology are all working together under one roof. Unfortunately, not all practices have that. And so in the community practice, really pushing our community members, if you're going to treat patients with alpha-1, to really start engaging your GI and cardiology teams to kind of work together on these patients. There may be a liver therapy coming out for alpha-1 for the first time. We're hoping the studies are looking pretty good. So we're hoping that does get approved for our patients with liver disease. So I'm hoping that will help GI and pulmonary practices in the community setting start working together a little bit better on these patients. And then we also have personalized strategies in treating these patients with alpha-1. We may also have some new therapies coming of inhaled alpha-1 protein for patients instead of getting infusion. So that would liberate patients who may have transportation issues. There are some recombinant therapies that are coming, which may help with the supply chain concerns, that we don't have to solely rely on plasma donations. And then, of course, new trials. And ahead of new trials really should be the discussion of screening. So these patients, we need to screen for alpha-1 so we can find more of these patients, so that we can study more of these patients. The subject population in a lot of these trials is very, very small, which can limit a lot of outcome measures, empowering studies for outcomes. And so we need to screen them so that we can study them. And the more trials that we have invested in alpha-1, the better we're going to understand better ways to treat, identify, and help these patients who have these diseases. So last thing I just want to remind everybody is that when we measure more than the numbers, we treat the whole patient. So just not focusing on those objective measurements of our alpha-1 patients, but also considering the subjective pieces too related to their quality of life, looking at their risks of depression and if they are actively having that because of the long-term outcomes that it has on patients participating in their care and really succeeding with their healthcare team in treating them. So thank you very much for listening, and I hope that you were able to take away some great points from today.